Good afternoon. I guess we'll go ahead and get started. For people on Zoom, if you're muted, if you please stay muted. But at the end, for questions and answers, you can put your questions in the chat, and I will monitor that. If you are in the room and have a cell phone, if you can please silence your cell phone, will be greatly appreciated. Ken Rad is here, who will introduce our speaker for today.
How's this? Any better? Better? Okay. Well, it gives me great pleasure to introduce a friend and colleague of over 30 years, Dr. Anthony. Yeah. Well, okay. Yeah, that's how far back we've known each other, both at the university, but also through Dance Alive for many, many years, in which my wife has been a big supporter and Tony has been a very big supporter as well as participant. In any case, Dr. Mancuso got his undergraduate degree from Florida State, his medical degree from the University of Miami. He then did his radiology training at UCLA, where he remained on the faculty for a few years before a stint in Utah, like some of our former football coaches, and then came to the University of Florida in 1983 as an associate professor, and was promoted within 3 years to full professor, and then 20 years as department chairman. So he's had a really rapid rise and illustrious career with over 190 peer-reviewed publications, 8 books, 25 book chapters, and numerous lifetime achievement awards. So without overdoing it, I'm pleased to introduce Dr. Mancuso.
Yeah, so everybody hear me all right? If I mumble, because I do that, I've been told I do that, my voice runs down when I give talks, so just wave at me if I start mumbling. And you overdid the introduction totally. You already overdid it. Okay, so Ken asked me to do this, and I'm pleased to do it. And so I made some assumptions about, you know, when you're asked to give a talk, you always have to consider the audience. So I made some assumptions that may or may not be true. One of the assumptions I made was a lot of folks that are here are from UF. I know that is a conduit. So I said, well, I'm going to tell some UF war stories about what I grew up with, and that's modern neuroimaging with CT and MR. I thought that might be of interest to you because at UF in particular, we were at the forefront in the United States on a lot of what went on that constitutes now current modern imaging. I'm a neuroradiologist, so I want to focus on the brain, the spine, the spinal cord, head and neck area, they call it, eyes, ears, nose, throat, balance, hearing, stuff like that. Okay, that's all within my domain, so I'm stick to what I know a little something about. And that's the context for the extraordinary developments in 3 things over the time I've been here since 1983 to 1925. So that's 42 years? Yeah, 42 years. That's how long I've known him. So we used to live right near each other over Old University Park. Is that what they call it, I think? Yeah. So, so one assumption I made is that since I'm an old guy and I like to tell war stories and old stories, that we're in an audience of peers. And you all have your own stories and you might like to hear some of those. Also, I think there's probably, how many folks here have been affiliated with the UF at some point? Well, good, then you'll enjoy hearing. So that's maybe half, that's pretty cool. So that one assumption was okay. And the other was that everybody in the room might have some interest in where we are in neuroimaging. And at the end, of course, I'll say, and what, and what's next, I'll tell you the end first. AI, everybody is all turned on about AI, and that will be the next great advance in medicine. That will be. But I've had the good fortune since 1983, actually, when I started my residency at UCLA in 1974, I happened to have the good fortune of hitting my first year of residency when first CT scanner came to California. And then, therefore, I've been able to actually experience the history of CT and MR, actually ultrasound, which I can talk about, but I'm not planning formally. So that an assumption I made is that you might enjoy hearing how those modalities grew up. You might enjoy hearing some sort of war stories and the people, some of who, did any of you all know Kate Scott when she was here? She was here for a while, yeah. Kate Scott was a resident here for a while who led our MR physics group, one of the best physics groups in the United States, if not the best, for a segment of time in the 80s and 90s. So I thought you might like to hear the connection between the evolution of CT, MR, the related communication systems that have been developed, and then maybe the UF ties into that. But if you have any other questions, clinical, where we are, what we do with these things, I've been told we'll hold questions till the end. I'm happy to do that. And then at the end and afterwards, if you have any personal questions about neuroimaging or things I'm going to not talk about, like ultrasound, just let me know. Okay, I have at least an hour or so after this, so I could be available. So, and please put your questions in the chat. That translator thing's pretty good. That's really good voice to text. As an interesting side note, I'll tell you later, maybe I'll tell you now, it's sort of interesting. One of the great advances in diagnostic radiology was voice to text. And so I'll leave that to when I get to it, because it really made a difference with regard to how diagnostic radiologists interact not only with the referring doctors, now with our enhanced communication systems with patients. How many of you all read your own reports? Some of you have to, right. So that's a relatively recent event. I think that's probably evolved over about the last 7 years now, to where patients, and how many of you read your own reports before your doctor gets the results? Right? And I'll tell you a little side note about that. So when I'm reading out these studies on patients, I do a lot of follow-up on cancer surveillance cases and things like that. Fortunately, our communication system now have gotten to the point where I can go into our Epic record, which I'm sure most of you are familiar with. I can put in a thing called a secure chat. If I see something that I don't want you to know before the doctor knows, I can send them a secure message. So it's really sort of cool. Everybody doesn't do that, but so we can talk about any of that kind of stuff, because I was chair for 20-something years, 24 years actually, yeah, 2000 to 2000, last year, 23 years. So, so the focus of this, we can go astray if you like, but the focus of this is going to be, what's happened between 1974, when the first CT scanner hit UCLA, okay, and then they got one up at University of California at San Francisco shortly after UCLA, and then when MR hit the ground here in 1983, which is why I came to UF to start the MR program. That's how they enticed me away from skiing in Utah, and so we're gonna. That's the way this will go historically. So I think. So I don't have a lot of pictures. I'm a radiologist. I should have a lot of pictures, but I don't, okay? I got stories. That's what I got there. But I do have a couple pictures which are really interesting. So in 1974, the first EMI, you all know what EMI stood for? It's an interesting story. Tell me what it stood for. Electronic musical instruments. You know what you know who owned them? The Beatles owned them. The company, and what was it called? Apple. That wasn't called Apple. And Apple's different. It was with an A. I've forgotten the name of it. The company that owned them, EMI, it was a company that you would know the name if I could remember. What was Apple, right? No, who said that? Yeah, I think that's right. Anyway, there was a company that owned EMI. EMI was electronic musical instruments. Their biggest revenue stream was the Beatles, but they supported the guy who invented the first working CT scanner in England. Okay, and one of the guys who was instrumental in that was a guy named Godfrey Hounsfield, and they actually named the units that we use to express density differences Hounsfield units. So but that unit hit UCLA in 1974, and I'll tell you, I'm sure many of you have had CT scans, so you'll know the difference between what I'm going to tell you. So it had this little gantry, and all you get was about half your head in it, okay? And they had to tilt your head, and they put it in a water bag. Not the, it was like a balloon. There wasn't water around the head, but there was water in this balloon. And they had to do that so that the machine could grab the data properly, the X-ray data. But is this a pointer too? I'm worried I'm going to push the wrong button. The red thing. Okay. All right. So am I pushing the right thing? Oh, that thing. Oh, that's a tiny little red dot. So I hope somebody can see it. But so I'll show you the water bag. I'll show you the gantry in a minute. It's one of the couple of pictures I have. But the way the scanners work now, they spin around you really fast, okay? But the way it worked back then is it would move a few degrees, and then the sensors that sense the X-rays going through, it would shift back, and then it'd go again and shift back. Well, all that to make one scan took 30 seconds, right? 30 seconds, and the slices were about a centimeter thick, right? And for the whole head, you get about 10 or 12 slices. To put that in perspective now, sometimes in the angiograms we do through the brain, we get 4,000 sections in 3 or 4 seconds, okay? That's where the technology has gone technologically. So it's very interesting. The other thing is, and I'm gonna contrast this with the kind of systems we know. You all look at your own pictures online? Yeah, you can get into Visage or whatever, our app, and you can go see all the pictures, right? Well, after we got these 10 pictures, they took Polaroid pictures of them off the screen, and they pasted them in a file folder, and that's how we read the scan, okay? Now, you're going to contrast that with what I'm going to tell you about what we do today, right? So that's where we started in 1974, sort of fun. Whoops, I didn't want to do that. How do I go back? That was a mistake. I know how to go back. Okay, there we go. So from 1974 to 1972, I'll just let you know that the gantries didn't spin yet, okay? So the next big thing that came along from this, but they got faster, a little faster, and they translated more. So instead of 30 seconds for a scan, it took about 5 seconds per scan, right? And that, in this time window here. And then we got a little bit thinner slices, right? Scan time went down some, from 30 seconds for one slice to 20 seconds for a bunch of slices, okay? But still, we wrote 20, 30 slices, not 5,000, right? Okay? What we get with the spinning gantry. And then around the late 80s, early 90s, we went to what was called rotate. So they invented gantries that would spin around you. That was the next big step, right? So we'll get to where we are today in a minute. And then they changed the detectors that are in these big gantries so that they can get down to really thin slices. What did that do? I don't know if any of you have had studies of your inner ear or your pituitary gland or something. Well, if you look at them with 1 centimeter slices, you get 1 picture. If you look at them with 1 millimeter slices, you get 10 pictures to look at close together. So it's much more precise. So that happened around 1992. Now, all of this stuff was independent of what went on here at UF. And I'll show you how we got involved in a minute in the next big phase of CT, which was huge. But first, I want to talk about the parallel developments in how we collect, distribute, and interpret our pictures. So I told you way back we got this folder with 10 Polaroids in it, right? And then for a long time, what we would do is we take a picture on X-ray film, right? You all, a lot of you as old as I am, you remember when you got an X-ray, it was on a piece of film, just like a photograph, right? Right? You take a bone picture, you take it. All that's digital now. But what we used to do is all the pictures that appeared on the consoles, all the slices through the body, we'd record those on X-ray films. So we'd have when we read the study, we'd have about 30 pictures on a sheet of film like that, right? Well, that all changed with the invention of what are called picture archiving and communication systems. And that's where the term PACS. You all heard the term PACS comes from? Yeah. Well, that's where it comes from. That's the term that stands for these systems that we now, instead of printing on film and all that, these are all digital images that come off these machines, right? We take all that data, we send the picture data to an archive, a computer archive, and then we can retrieve it, and then we have ways of looking at it all different ways and analyzing the film. So huge change. And what I want to credit UF with, there were 2 people here. Merrill Frost, who still works with us, who built the first archive in the United States. A lot of other people take credit for it, but Merrill Frost built the first archive in the United States. We had PACS in 1994. Most people didn't even venture into it until the late 90s, okay? And we had also a very talented computer scientist named Janice Honeyman, who was Merrill Frost's partner. So any of you who knew those names or were hearing those errors, I did nothing of this. I just was lucky to work with all these smart people. So we had that, that's good spelling there. Hard, well, I think I need a little help from spell check. I think spell check did that. I didn't do that. And then we talked a minute ago about how refined voice to text is. I mean, this is like incredibly accurate voice to text that I'm looking at here, right? So the interesting thing, have any of you been in that end of the business, PACS, voice to text? Did any of you know the first company that did voice to text commercially? It was IBM, okay? It was IBM. And IBM came when I was, before I was chair, but when I was in the department in charge of these things, I found 2 companies that did this. One was called PowerScribe, and one was IBM. And they gave me this headset, and we demoed them, and I looked at both of them. Suffice it to say, IBM died, PowerScribe took over, and there's a couple of other companies in the business, one from Europe and whatnot, but PowerScribe is the dominant. We were the fourth customer of PowerScribe in the world. So we were into this, and part of the reason for that is I was overreading studies for an oncology practice, a radiation oncology practice, South Georgia, and I needed a way to dictate my reports and send it to them. So that's how I got involved with it, got them down, and we've had a very long-lasting. So the guy who was sold that to us, who was he was a VP at the time, He is now actually runs the developmental group for PowerScribe, and they are now owned by Microsoft. So because of those relationships back in 1974, we have direct ties into PowerScribe and Microsoft development teams, which has reaped benefits for our department over others. That's some more interesting, the way things work in the world. I'm sure those of you who have been in business know how networking goes and how much fun it is. So, all right, so I promised you a couple of pictures. All right, so that's Godfrey Hounsfield standing by the, remember I told you about the water bag? First CT scanner. So that's the little hole your head went in. Okay? You can't see the water bag, but it's in there. Okay? And so they couldn't even put your whole head in it. They had to tilt your head in a funny position to see the brain, right? Or they get too much of the face and not enough of the brain. So that's what it started. And this little thing, that's the gantry. That would, the detectors would run parallel like this. Whoops. They'd run that way, right? And then the whole thing would shift a couple of degrees, and then they'd run again and run again. And you're laying there and made these sort of really crappy pictures of the brain. I'll tell a personal anecdote. I was an intern at Mercy Hospital in San Diego. Really nice hospital. And I was downstairs with the radiologist, and they showed me this brochure about this scanner. And on the front of the brochure, there was a picture of the brain. Okay. Before that, all we had was pictures of the skull. You can see the brain. You don't see the brain. Sorry. Unless you put air in the head and all sorts of barbaric things we used to do, right? Truly, almost like leeches, or bloodletting. But you never saw the brain. So I had the brochure, and then they had this crummy picture of the brain with 64 by 64 matrix. We now do 512 by 512 matrices, by the way. That's the difference in resolution. But on the front of the brochure, I was sitting with the radiologist. He said, well, this doesn't look like much. And I said, I used to serve, so I said something, dude, you're looking at the brain. Actually, that's why I got interested in when I first got to UCLA. Interesting that, he didn't find it interesting that you could actually see the brain. Funny story. So anyway, so I promised you a picture. Those are all the little Polaroids. See the little Polaroids? Those are the Polaroids that came off the machine that, they come onto the screen, and they had a Polaroid camera mounted to the screen, and they took those Polaroids, and then at UCLA, we stuck them in a folder. Yeah, I guess we could have just looked at them like that too, but. So just this is a picture of the scanner that we were the 4th in the United States to get. This is now the state of the art of CT. So I'm jumping all the way from that development to what we have. It's called the Aquilion. It was made by Toshiba, which is now Canon. Canon bought Toshiba. But we had the 4th machine in the United States. I take great pride in saying we beat the NIH. We had the 4th CT scanner. Why is that important? The man who came and demoed this to us when they were selling it, I forgot, I think Harvard got one, maybe Duke got one. They were a little ahead of us. There were 4 big places, 3 big places ahead of us, but we beat the NIH. We were number 4. NIH, I don't know, it was somewhere down the line. So, but this was monumental. I sat and watched a demonstration where they showed us what this scanner would do. What's unique about this scanner is it spins so fast that it can stop the heart beating. Okay? Right? Essentially, it can go fast enough that the motion of the heart doesn't hurt the images, which means you can see the coronary arteries. We stick a little contrast in the arm, and you get an angiogram, right? So this is the birth of CT angiography. This has replaced almost all of diagnostic angiography. I'm a neuroradiologist. Until this scanner came out, I would have to get up at 3 a.m., put a catheter in somebody's groin, and shoot dye up into their head to see their brain. Now, that's mostly done a little for diagnosis, but mostly for treatment now. And neurosurgeons do. I don't do that anymore. They treat aneurysms all with catheters, all sorts of fancy stuff. So this is monumental. Also, it's taken the cardiologists a long time to give up all their angiography because it's not a bad profit center, right? But you can also do coronary angiography with this thing. So when they came in and demoed it, they would demo it, and it's a heart machine. But I watched the blood go through the brain light up, and the arterial phase, the venous phase, and the capillary phase right in front of me. And I said, no, man, you don't have a heart machine here. You got a brain machine, okay? And it turned out that the applications in the brain were far superseded the early applications in the heart. It took the cardiologists a long time. I don't know if any of you have had a CT angiography of your heart. Nowadays, you might have one of those instead of a cath, okay? You might. It's up to the cardiologist. But we did make peace with the cardiologists. We let them read these studies equally with us. We didn't fight over it. A lot of people fought over that, but because a lot of money. Is this being recorded? Uh-oh, I shouldn't have said that. Oh, well, too bad. So this is called the Aquilian 1. It's still by far the best of breed. There are some other companies that have learned how to go that fast, but the solution that Canon came up with took them 10 years to develop that gantry and the software to unscramble the data that flies into that. Billions and billions. If any mathematicians in the room, there are very complex Fourier. I hate math. Let me be clear about this. I hated math from trig on, okay? But there are very complicated mathematics to spin a gantry around, get 3,000 or 4,000 pictures in 3 or 4 seconds, back project them by something called a Fourier transform. I only know the words, I don't know how to do it, okay? And get these pictures to spit out the other end. But Toshiba, now Canon, was the first and still the only people who really solved this optimally. And so we bought into this technology when it was first available. Must be 15 or 18 years ago now it came out. And they're still best of breed, okay? And therefore, UF became developmental partners with Canon and Toshiba, and we had a special relationship with them for many years. Again, another bit of a war story. And so, guess I've already told that part of the story before I put the slide up, right? So there you go. So this is called volumetric CT, okay? And what happens is, to get these pictures, the other big development was, while the tube's spinning around inside that gantry you saw, the tables move automatically, right? So, and then the biggest thing about this one was they had a field size that was 16 centimeters. And it so happens that you can get most hearts and most heads inside of 16 centimeters. And that's where the other companies fall down. They sort of split it up and do weird stuff that I don't agree with. So we made the better choice here. So not only has this technology eliminated, fair to say, 80 or 90% of diagnostic angiography, including things like runoffs in the legs, studies of the heart. I mean, that's already the great vessels, right? So it's eliminated catheter angiography, much of catheter angiography, right? So that's a lot of people not getting holes poked in their femoral arteries or in their brachial arteries, right? It still hasn't replaced as much coronary angiography as I think it should, but that's my bias as a radiologist. It may not be right, but I'm opinionated for sure. And then the other thing we can do, so because this acquires so much data and we can watch the contrast flow through the brain, like I said a minute ago, we can actually look at the blood flow in the brain by factors called perfusion and blood volume. We can know how much blood volume is going into the brain per unit of time and how the brain. So what does that mean? That means if we do this, we get data instantly about whether there's brain at risk in somebody who's got a weak arm, or whose vision goes out, or has any other symptom that suggests an acute stroke. Major advance. Um, this technology obviously isn't on our mobile stroke unit, which is another great advance that they made here. But once they hit our ER door and we do this, we can figure out pretty quick that there's something that the neurosurgeons have to get in, and or the neurologist, and bust up with clot busting drugs, or go in with a catheter and a retrieval system and pull the clot out. Huge advances because of this technology in stroke. So, and other diseases. So as a neuroradiologist, I sort of focus on that. So I still take call. I work every day. I work 12 hours a day on the weekend days I work. And I will see a minimum per shift of 6 CT angiograms with perfusion studies in people who come through the ER with symptoms of potential cerebral infarction and what's commonly called stroke. So huge impact on patient care. And again, UF was, I'm proud to say, was at the forefront of that. And I've already told you, before we've gone in 1974 to 30 seconds for 10 1-centimeter thick slices, and now we have thousands of sub-millimeter sections in seconds. So I hope this is information that's sort of fun for you to hear. If it's the other thing, so I'm trying to blend together the modality and how we look at the images, and I've alluded to this a little bit before. So, whoops, gotta go back. So again, at UF as early adopters, there are all sorts of people out there that give you a way to look at these images on a computer screen. We were fortunate enough, with the advice of Merrill Frost, who built our archive. We transitioned from his system. We had Merrill's archive for almost 30 years, but then the hospital said, we have to go to a commercial archive. So Merrill helped us find a company, and we found an Australian company named, what did I do? I went the wrong way again. Named Visage. They had one customer in the United States. We analyzed them. They were by far best of breed. We were their second customer because of Merrill's advice. That's where you're seeing your images now, on your phone or on your iPad, right? Nobody else had that then. And then because of the experience here with us, because we were their second customers, there was an outfit out in Sacramento. They were their first U.S. customer. Because of our recommendation, these instruments, this Visage system was sold to Duke, Harvard, and the whole University of California system. But our experts here, who were advising me, said, this is best of breed, you got to get it, there's nothing better. And that's why we are so out in front. And that resulted in them donating a whole system to us just for education, which we've had for years. So we've been using their system to educate our trainees, our medical students and residents. So that's how UF has synergized these corporate relationships. So I've already said what Visage does. You've experienced it. We can look at images every which way. We look at the perfusion images with it. We can look at various planes. We can do a fair amount more than you can do on your phones, right? Or our clinicians can do on the phones. It's extraordinary what we can do. We gather this data. It costs a lot of money to gather it, but the ability to analyze it and analyze it quickly. I can look at one of those stroke scans, no lie, in less than 5 minutes, okay? Thousands of images, less than 5 minutes, get an answer, get it to the neurosurgeons and the ER docs. Unbelievable. And by the way, we were actually, I forgot to put this on the slide, we were the first company with Toshiba when Adequillion got here to allow the data to be processed and delivered within 5 minutes. That was because of our relationship with Toshiba at the time. So it's sort of fun. With regard to CT, what are the works in progress? Where are things going? There's a thing coming out called photon counting. It's like fancier CT with more detail. So it's still moving forward, but you've seen the major advances. And then we're going to talk about AI later. Now, I'd like to, I don't know, how much time do I have left? Okay, I'm good for a while? I don't know, I'm not keeping track. I'd like to sort of take a trip through MRI, okay? So this is, if CT began in earnest in clinical practice in 1974, which it did, and the technique spread wildly from that origin, a decade later, the same thing happened to MR. Roughly 1983, I came to from Utah to here to start the MRI program, and I'll tell you the people who were involved in that in a minute. But while I was at UCLA in the late 70s, I went to this meeting in Las Vegas, and they were showing X-ray stuff and CT stuff, but they also showed images, early images done on something called MRI. Now, I didn't know what it was. Found out it's just a big magnetic field and some antennas, and you can make pictures inside of things. They showed pictures of an orange, and I said, this is pretty good. And then about a year later, they showed a picture of a brain and a bone and hope. So MR technology really got delivered by a couple, developed by a couple people. I'll show you in some pictures here, and one of whom got the Nobel Prize for it. I got a picture of that in a minute. But that's where it started. So before I left UCLA, that's when I got interested in it. I actually got UCLA to put the first commercial MR system in place in UCLA, and then I left. Not very smart. But it was a low field unit. Okay, you see that says 0.15 Tesla? That's the field strength of the magnet measured in Tesla. Teslas, the unit. They are now 1.5 and 3 Teslas. So 10 to, what's 2 times 10? 200 times, 20 times the field, or whatever it is, do the arithmetic. But a lot more powerful magnets. It was developed by a guy named Damadian. He didn't get proper credit for what he did. The guy who got the credit for it was Paul Lauterbur, who got the Nobel Prize in 2003. But this was not new science. This grew out of what was called NMR, which is a methodology to eliminate the, to probe the structure of molecules, okay, analysis. So how do things happen? So when I was being recruited here, the chairman who recruited me had assembled a group of NMR scientists. Kate Scott was in that, and they recruited a young man named Jeff Fitzsimmons, and there were a couple others, but they put it together as an NMR group. But that chair who recruited me had enough insight to understand that MR was going to happen. That's actually why I came here, because Utah was behind. I said, UCLA's already got a unit. When are you guys going to get one? They went, duh. I mean, this was 1981, 82. And I said, well, I'm out of here if you guys aren't going to do that, right? And that's, so this science group was here. I came here. I met a man named Professor Raymond Andrew, who was brought here by the engineering group. Professor Andrew became a great friend. He officed next to me. And Raymond Andrew worked in the lab of Block and Purcell, and those are the guys who sort of invented NMR, okay? He was their student. And they were all people who developed the radar systems that were used to fight the Nazis, by the way. That's the lab this all came out. Just interesting. I hope you like the war stories, because I find them fascinating, these connections. But Raymond was one of the best MR scientists in the world. He got the Wellcome Award, which is the highest award in England. It's sort of a cut below the Nobel Prize. But I had the good fortune of sitting next to this genius on a daily basis who taught me all about MRI. So what happened, but this was old science. Tesla the genius, the incredible genius, Tesla, he already figured out that this could be done and patented it in 1882. The concept was patented in 18. That's how smart that guy was. Unbelievable. In 1984, we installed the first low-field unit in the United States here. And in fact, because we did that, they gave us another unit for free to do research on. And this was Technicare at the point. I'll tell you an interesting side note, in big business, GE actually ran Technicare out of business. And the little story there is, do you all remember the Tylenol scare? All right, and you remember the parent company of Tylenol? Johnson & Johnson, J&J, I'm sorry, I blocked on it. J&J was the parent. Do you like this kind of story or not? I mean, I can bore you. If I'm boring you to death, let me know. But this was fascinating to me. So J&J owned Technicare. Technicare sent us these units. They were first into MR and followed quickly by a couple other companies. The Tylenol scare came. Johnson & Johnson got hit for a lot of money because of that. GE got into the MR game, and because Johnson & Johnson didn't have enough money to fight with Technicare, Technicare pulled out of MRI. That's the way things happen. And that's how GE became dominant for a while. And then Siemens Corporation became the best of breed after a while. So just a little story about how all that happened. How things happen, I don't know. You know, I believe all things happen for a purpose, but it gets wild sometimes. And that got pretty wild. Then in the mid-'80s, they had these intermediate field things, but GE and Siemens pretty much forced the system to go from 0.15 to 1.5, 10 times the field strength, and then that was doubled. You all know the Mangurian, you know what, any of you guys know where Fixel is? Down on Wilson Road, right down Wilson Road, yeah. By the way, I'll just credit Mike Oken, got Mr. Fixel to contribute a lot of money to build that place. Well, inside of that, we managed to get built a facility with incredible MR machines and something called a MEG unit, a magnetoencephalography, revolutionary time. It's right down Wilson Road here. You'll see it, Fixel Institute. So what we had the chance here, we had two choices. We could either partner with GE and develop an intraoperative MR unit, or we could Siemens do that, or we could partner with GE and build a 3T machine. Well, we chose to help them build their 3T machine. Oh, that's the Madian, the guy who built the first unit and didn't get credit for it. That's Paul Lauterbur, the guy who won the Nobel Prize, the scientist who won the Nobel Prize for MRI. And that's Peter Mansfield. And Peter Mansfield is very interesting because Lauterbur used to come by and visit Raymond Andrew here, okay? And so much fun. And Peter Mansfield also was good friends because he was British well, both those guys were British. And that's Raymond Andrews in our physics group, his lineage. That's how good he was. And that's why we had the NIH resource grants back then. So the technology grew up to 3T, which is now what we have down at the Mangurian Imaging Center at Fixel. We got two of them. But the other big thing that happened with MRI, it got so good it can map the brain, and it can map physiology in the brain. So we can study a brain's function, what they call neural networks, and we can study in great detail the brain structure. And so what we opted to do with a great scientist, in the, I keep doing that, in the neurosurgery department, Frank Bova, and Jeff Fitzsimmons, who was recruited by Kate Spott way in the early days before I got here. What they did is they were the first people to figure out how to stimulate the brain, how to give the brain a task while somebody's in the MR unit, and then map the brain function. Okay, so that was first developed here by Frank, who was in radiation oncology and then subsequently went to neurosurgery. He's a genius. And so we had the first functional stimulus box hooked up to then a donated GE small bore unit. You can only get the head in it, and that's how we got started here. And that's how this, what's called functional. Have you, any of you ever heard of functional MRI, fMRI? Yeah, right. So that's what it is. And it's amazing. You give the brain a task, you look at oxygen utilization in the brain, it unscrambles the picture, and you can start to map out what we call neural networks. The brain has all these neural networks that are on their own and interconnected. It's fascinating. And I'll give you an example. How many of you take a guess at what activity lights up more neural networks in the brain than anything else? Pardon? No. Well, good, probably. It lights up certain ones. Well, the oxygenation is what's measured, but I'm talking about the activity. If what? Well, I don't, yeah, they have studied that, but I'm not familiar with the literature. It's actually playing a string instrument. Think about it, right? It's motor, whatever you're playing, right? You're reading music, so it's visual and you're processing that, and you're hearing it, okay? So it's actually the arts, and I'm a big advocate of arts in medicine. It's actually the arts that light up most of the brain. Guess what puts you in your lizard brain? All your cortical function goes down to what we call default networks. Fear, okay? Puts you right down, and what I tell my kids, you're in your lizard brain right now. You know, you have no frontal lobes. So anyway, it's sort of interesting. So just a little side note that this was first developed by these two. Jeff is a genius. Y'all have been in MR unit, a lot of you, and they put what we call an antenna, but we call it a coil around your head or around your knee, wherever. They put a coil close to where they're studying, because what we're doing is we're pumping in radio frequency and getting out changes in the way protons are aligned in the body, right? So you have to catch that signal coming out. So you have to put an antenna real close to what you're studying. Jeff Fitzsimmons had a company here. It was down the road. It was out on, what's the road that goes to the airport? Waldo Road, right? Big company out there that he developed most of the coils and the coil technology for most of the industry, okay? Sold the company for $50 million, and I did not have a stake in it. Or I might not be here today. But that was split five. They split it five. He could have sold it for a lot more. I think he sold it cheap, honestly. But they each split up, I think, $5 million in cash and $5 million in stock. I think that was the deal. But I think they got taken, actually. So anyway, that early coil development, we had people coming from all over the world to visit with Jeff about how to build these coils. So it was a really interesting time. Again, for you that have been associated with UF, this is sort of a bit UF-centric and a bit global discussion. And then the other cool thing that we had, all this stuff that comes up about TBI, Toshiba actually lent us a unit to study TBI in athletes. And I don't want to get into too much detail about that. So, and I had it on the slides, and so that's all what I just told you about. Okay. And the other thing we did is with this technology, it facilitates the research of people. For instance, y'all, I'm sure some in this room have had orthopedic surgery. Anybody had a total knee? That's pretty common. Well, if any of your friends have had total knees, Catherine Price, a very gifted researcher, she's studying what happens to people. She uses functional MRI before and after knee surgery, because it's usually in people that are like our age, like I'm 77. But she studies people who have had knee surgery and studies them before and after and looks at the effect of prolonged anesthesia on the brain. And it's part. Did she? Oh, Kate Price is incredible. Well, the other thing about Kate is she's so good that what we did is we were one of the first places to get into using the technology to analyze these networks in the brain. After Jeff's invention, then it went commercial, and so we were able to, with the money Jeff gave part of his money back to the department, and so we like bought Kate Scott this stuff to do these kinds of studies. So that's how these things have worked for us. So, and then I've already told you that 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 we've taken this technology, right? Got 2-3 TMRs down the road, quarter of a mile away or half a mile away, right? And then a MEG. MEG first came to my attention when I was at Utah in 1981. And I had been after UF to get a MEG unit here for a long time. Dr. Tischer, you know Dean Tischer? I don't know. Yeah, great guy, just incredible dean. Craig and I really got along well. We all tried to get a MEG here in the 90s, didn't work out. But Mike Oken went out and got raised enough money that we could get a MEG here. So we're about one of 5 places in the United States. All the credit to Dr. Oken for raising that money. And now down the road, we have one of the best, probably 3 other places, maybe 5 in the United States that have a facility like you have a half mile down the road here. And again, I have to credit Mike with getting the money to do that. It was fortunate that we waited. You know, I got a little annoyed when they wouldn't buy a MEG in the 90s and early 2000s. I said, you know, why are you guys dragging your feet? And then Craig retired from the deanship, and we lost some momentum. Turns out it was better because all things happen for a reason philosophy. The MEG we have now, it was good to wait because the technology is mature. So it's a lot of fun. Okay, and the very end, I hope I haven't gotten too far over time. I don't know what time it is. But so what's next? I told you at the beginning. I tell you at the end. So arguably, I've been very fortunate to have my career just parallel all these developments. I've learned them along the way. I always tell our residents I feel sorry for them because I grew up and learned this stuff incrementally. Now when they start and they have 4 years, they got to learn all this stuff from scratch. I said, I don't know how you guys do it, you know. But the next thing, so I've shown you ultrasound is another big thing. I didn't have enough time to talk about that too. And ultrasound grew up in parallel with all of this, okay? So if you accept that CT a decade later, MR were extraordinary advances in diagnostic imaging, what AI is going to do is just make us much more refined. So, and how's it going to do that? Oops, I keep doing that button. First of all, MR, machine learning, that ML is machine learning, AI is artificial intelligence. Machine learning, they're the same thing. You teach machines how to do things that humans do. That's what machine learning is. It's not really fancy. And what does that mean? Okay, so if you want I'll give you an example of how it'll help us. Read studies. If you give a machine 100,000, a computer algorithm, 100,000 brain CTs from all across age ranges, then that machine knows what's normal or abnormal, right? Therefore, that machine can tell a radiologist that's reading a study, you call this normal, but I don't think it's normal. The machine says, I think you're wrong. Go back and look again, because I think I see something. Okay, so what does that mean instantly? It means it'll reduce error, right? Okay, because the only thing in all the time I've been in radiology now, which is 1974 to 2025, God, it's 50 years, okay? The only thing that's ever been proven to consistently reduce error in radiology, can you guess what it is? From what I just said? 2 people reading the same film independently. So if you teach a machine to be able to do that, okay, then you have the best tool to reduce error. All right? So it's going to help us. But the danger is there's going to be people out there that are going to let the machine read it first and say, oh, I believe the machine. I'm not even going to look at it. Trust me, there are people out there that will do that. Not here in our practice, but in other places. That's my opinion. That is my opinion. Okay? May not be true. That's my disclaimer for whoever's going to look at this recording. Let me put it this way. It's a danger that people will let the machine do it and get lazy on their own. Okay? So my attitude about it is if we let, and they've been doing this with mammograms now for, I formed a relationship with a company about 8 years ago now to overread screening breast mammograms, right? Okay? Not to read them first, but to let the radiologist look at it with their own discipline, then say, machine, do you see anything else? And the machine has seen, I have 500,000 breast MRs, right? And the machine will go and it'll flag things is wrong, little what we call microcalcifications or suspicious mass, and it makes the radiologist go back and look. So you know that's going to reduce error. So that's my pitch where, but I don't, there are studies out now that if you take bone x-rays from breaks and stuff like that, that the machines are as good as the humans. That's okay. I'd still rather them be second, right? A second opinion. I think it's, in England, God bless the UK, it's my understanding that they actually accept the reading of machines for regular x-rays, like chest x-rays and bone films. I don't know if that's true. It's sort of hearsay that I repeated. I haven't read studies. But there have been studies that in certain circumstances show that the machines are as good as humans, okay? And you can let machines do tasks. Like we get all these films in kids, especially with scoliosis and things like that. Well, you can let them, all that's doing is measuring angles and stuff. You can let a machine do that. That's okay, right? But I don't think you want a machine only reading your mammogram or your brain, all right? The other thing, which is very interesting, and we began working on with so PowerScribe became Nuance, and that VP that I met back in 1997 became the developmental person for Nuance and working with Microsoft. He and I both believed, I have a little less leverage with him now that I'm not chair anymore, but we believe that AI can inform the reporting process, make it more accurate, more crisp. Have you guys gotten a radiology report with bad grammar, bad punctuation, and misspellings? Yes, I know, because even though I proofread my reports, I think sometimes there's errors in it. It sort of makes us look a little dumb. So machine learning can clean up reports that way, okay? That's a minor task. You can't change the meaning. You don't want it doing that. However, if I'm doing a report about, let's say, something I see in the brain, and I'm speaking, you can teach a machine to watch me speak. And if I say certain things, the machine can say, oh, since you're saying that, why don't you also think about this? Okay? You got it? So I firmly believe that advanced AI will help us as it understands what we're doing as humans. It will sort of try to read our minds a little bit and say, do if-then statements. Well, if you're thinking that, you should also think about this. If you're in this clinical situation, you're considering that, but also consider this possibility. And you could get real-time feedback while you're, now that's sort of a pipe dream, but I think it'll come true, okay? And he believes it too. So what does all that add up to? I have a scary statistic for you, okay? Since 1950, it's been reported over and over again that there's a 30% diagnostic error by radiologists and anybody who reads x-rays, 30% error rate in positive radiology studies. It has not changed. That error rate has not changed since the first articles on that in 1950. When I say that to a non-medical group like this, it scares them. And so I've been trying to educate that out of the system by some very disciplined approaches to medical education. We actually have an online e-learning tool called Wisdom in Diagnostic Imaging. You could go look at it if you want to. It's online. It's free. All you got to do is put in an email address. Wisdom in Diagnostic. It's WIDI, W-I-D-I, online.ufl.edu. I don't make any money off it. The department doesn't make any money off of it. I put a lot of money into it when I was chair. That's not going to eliminate the errors. One way it is how we educate our trainees. But I think one of the biggest contributions of AI is going to be in reducing error. Both observational errors, there's two parts to radiology, observation and interpretation, okay? Most of the errors in radiology are interpretive errors, right? They call a study negative when it's positive. They miss, it's a miss. They don't see something, right? Right? So they call a study negative when it's really positive. That's 80% of the errors. The other are reasoning errors, not understanding the situation you're in, the military terms, situational awareness. When a radiologist looks, when I train the trainees, I said the two things you need. You need observational discipline and you need situational awareness. Because you have to be thinking about what you're doing and what it means to the immediate medical decision making. That's what that. And I think AI will help with that, therefore it'll reduce errors. And I think that's my last slide, and I hope I haven't gotten too far over time, maybe, or bored you to death. 2:31, and it started at 1:30. 1 minute overtime, not bad.
Oh, thank you, Tony. That was wonderful and really appreciated. Hard to know where to start. I see too many hands to count. We'll go right here. Alice?
Thank you. I appreciate the presentation. I have a layman's question, and that is, it's been probably 25 years since I had an MRI, and it terrified me because I have claustrophobia. So I'm wondering, with all the advances, do you still have to have either a full body or an open MRI, or can they do it just at the head?
That's a really good question. So there are, do I use, do I share this mic now, or do you want me to? I can still do this? Yeah, okay. So it's an ongoing problem. We have a significant number of patients who still have that. I didn't show you the gantry for MRs, but they're similar to that donut that you get, but they're worse. They're a tube, all right? So most of the people who have that troublesome claustrophobia that you have, they get it when you're entering the tube. It's a panic attack almost, right? You've experienced it, and it's real, and it's very real for whatever reason. There are options. One option, if it's not really severe, as you might know, is you could try some sort of a sedative. I don't much like Valium as a drug, but I think that's what still gets recommended most of the time. So that's one option. The other is there are more open architectures. The problem with the so if you just need your knee done, or your neck done, or your back done, open architectures are fine. If you need a functional MR of your brain, or a highly detailed study, or a stroke study, well, the stroke you can even do on the open ones, okay? But if you need a super detailed study, the open architectures, by open architecture, I mean, so instead of going into a tube, there's like a slab above you and below you. So you can see out both sides. You still sort of have to go inside the slab. And there's even more open architectures where you're just sitting, right, inside something that's around, but you walk into it. So it doesn't have that bright. So you can solve that with open architectures. The other way they tried to solve it, it doesn't make much difference, is with short bores. Instead of this long tunnel you go into, they invented some short bore. That took care of some people, but we still have, and of course, babies you have to put under anesthesia, just as an extension of your question. And it gets so bad that sometimes people who are claustrophobic, they just need to go to sleep. Put them to sleep. The anesthesiologist, I don't put anybody to sleep. You got to get anesthesia in, incur that cost, and anesthesia always has a risk. As good as our anesthesiologists are, if you don't have to get it, Did that answer your question? Yeah. So we manage. Look, if it's really medically indicated, you really need it for medical decision making. I haven't seen a case yet where we didn't get a scan we needed, but it may be anesthesia.
A quick comment and a question. The comment is that Jeff Fitzsimmons was a student in my laboratory in psychology,
Right.
not engineering.
Right.
But it was clear his hobby, as he thought of it at the time, was really on the engineering, and he made a wise decision. He graduated with his degree in psychology, but clearly he moved on. And ironically, I started doing research later on in fMRI and finding out all of the marvelous things that he'd done. And so I got to benefit from him much more than he benefited from me.
I think I'm trying to remember. I'm not great at names, but I think he talked to me about you and those. He certainly talked about his psychology. The other interesting thing about Jeff is he was in the Navy. He was stationed in Cuba, and he was a spy.
I did not know that.
Yeah, that was his job in the service. He was well, he's a spy. Whatever instruments they had down there, and they were watching things, he was watching them. Jeff was fascinating. His background was psychology. He had
Peter Lang.
Peter Lang. He loved Peter Lang, and I guess you were his mentor too. But Peter Lang was, I don't know if Peter's still with us or not, incredible guy, absolutely incredible. And they were sort of in that domain together. But Jeff was a tinkerer, and he was an instrumentalist, which I think is what you meant by hobby.
Mhm.
And I tell you, we had a patent together. I never made any money off it, but I have a patent. I still have the coil that we built together. The first coil that went around this part of the body, we built it together. You can see the little resistors on it. I got in my office, right? And he loved to tinker. A great guy. He's now taken a lot of his money, and he tried to put it towards football injuries and TBIs with that. And he's doing great. He's mostly taking care of his family now, so.
The question,
Yeah.
or it's not a question, really, your comment. When I was working on this, even under a 1T machine, you had to be extremely careful about what things you could bring in and get close to that machine.
Oh, yeah.
I can't imagine what you must have to do to deal with a 3T machine. So my question is, how do you manage that?
Yeah, talk about war stories. So there are instances of serious injury and death of people who open. So first of all, there are safety zones around all these MRs. But even with that, there have been anesthesia machines pulled into them. That's a little side note. We developed here the first MR-compatible anesthesia machine here. We have a very talented anesthesia group, and they developed the first MR-compatible anesthesia machine. But yeah, there have been waste baskets, waste cans pulled in. A janitor opens the door. There have been people killed by things getting sucked, and it's way worse at 3T than it was at 0.15 or 1T. You're right.
I think we're going to have to take one last question. One last question, and then we have to vacate the room, and Dr. Mancuso has agreed to stay around. if
Yeah, I'll
people
stay
have
in the
questions.
back. Looks like you got a group there that wants to get in here and make some music.
My question involves cancer monitoring and the precision involved with the scan, because the reports come out to say no evidence of, those are sort of the magic words in a report, no evidence of cancer afterwards. And so my question is, how precise, how many cells have to show up in a scan? I've heard it's not 10,000, it's not 100,000, it's 1 million.
Might be 1 billion. So here's the story. Don't hold me to this, but in 1 cc of cancer, there's millions of cells, and there could be billions. So, here's the deal. When we do surveillance imaging with a structural anatomic study like CT or MR, we're looking for macro disease you could actually see with your eye if you could cut into the body like the machine does, right? So microscopic disease, forget it. We're nowhere near that. all right? We're generally looking for things that are, let's just for sake of it, a centimeter or higher. So with regard to your number of cells, that's going to be in the range of millions of cells in a cc of tumor. The language in your report will state in these cancer surveillance, we do a lot of it, and it differs with the cancers in the part of the body. But the reports are going to say one of three things. All I see here are treatment changes that are stable, okay, and there's no change. Or I see something here that is suspicious, but it really doesn't rise to the level of I'm worried about recurrence. We're talking about anatomic studies, not physiologic, okay? So I see something, I'm a little worried, so let's get a scan within 3 months, because most cancers will not change much in 3 months, right? And see if it's still stable. The third thing will be, I see something that worries me enough from what I see that either we have to do a scan in a month or so, or we got to go and somehow, whether it's through a needle put through some part of the body or something, get some tissue and or follow it carefully. That's on the anatomic side. On the metabolic side, you're still looking for lots of cells, like with PET-CT and things like that. That's more physiologic. There are actually specific tumor imaging agents. I think that'll get better. You know, similar to immunotherapy, they could start creating things that can go and target, you know, cells that we might see it earlier. But to answer your question, it's a lot of cells if we can see it on imaging. And in response to your question about a report, that's what you're going to hear. That's the best we can do at radiologists. We're not worried, looks good, it's stable. Get a follow-up whenever you want, depending on like things like if you have thyroid cancer, they measure thyroglobulins or calcitonin. And now they have what are called liquid biopsies. And they're doing blood tests to see if there's tumor DNA floating around in your blood. So that's going to change all of this, and it already has. So at the cellular level, it's going to be more like what they're calling liquid biopsies, not imaging. I think imaging will get a little more refined, but it's not going to change much. And that's the way we report it, and that's the best we can do. Yeah, I hope that answered your question.
Well,
Thank you, Tony. Thank
Thank
you,
you.
everyone, for coming.
thank you very much, Tony. It was terrific, and apologies to those of you that we kept from your meeting and your new seats, and apologies to those on Zoom that we couldn't get to your questions.